So it's called Smile Cloud, and actually the presenter, or one of the two presenters at the course is the co-founder of this program.
Hey,
Uh,
Chad, before you go on, for the
yep,
others that are newer here,
yep,
our goal with this group is efficient, comprehensive, and thorough treatment planning. So,
yep.
any tool that you come across that might help us in this endeavor, we're always open to sharing. I do think that this particular program is probably the first thing of its kind.
Hmm.
We kind of have something like this. It's a makeshift potpourri of different products where I think this brings a lot of things together.
Yeah.
But our goal is to be able to have all of the information at our disposal when we're treatment planning. The,
Hmm.
the goal is never to treatment plan chair side. I'm not that good. Dr. Pierre's not that good. And I don't think anybody here is that good for cases of this complexity. So the goal is to get all the information so that when we have downtime, we have the clarity and the information necessary to come up with a good set of options. And this is one of the tools that I think will help.
Are you able to see this here, Nick?
Yep. Yeah, looks great.
All right, so this is kind of the home base here. So you just can add cases as you need to here. Um, and so there's a lot of cool features about this thing. First of all, you upload all of your files into this main area here. It takes STL files, it takes the DICOM files, JPEG. Obviously, these are just JPEGs of the X-rays, and then some screenshots of the scan that I had that I threw in here. But just from this main area, you can look at everything in a centralized area. Um, Obviously, it's not quite as interactive as like the MyItero site for it, but it gets the information across that you need. As far as the JPEG images, there's you can crop, rotate, do everything that you would need to. So it kind of acts as a photo editor as well in that aspect. Um, and then another cool aspect of it is that there's annotations on this, so you can let's go. I did one earlier, so you can draw on it and then do like a little annotation saying like the midline is off on this. And this, I guess let me back up here. So you can invite people to this to each case individually, so that you have so each person involved in the case has access to all of this. So if it's, for example, if I'm doing the restorative aspect and then Dr. Regan is doing the implants or something like that, we both can have access to this and communicate through this sidebar here. And any annotation on it would go in this sidebar here that you can type into and talk back and forth about it.
Hey, Chad, you know what I love
Yep.
about that?
Yep.
When we have our problem list, the
Hmm.
problem is the problem list doesn't have the pictures. This would be
Exactly.
a beautiful augmentation of the problem list so that if we ever have to have the patient revisit a problem,
Hmm.
it's in their vault. And that is
Yep.
one of the things in our practice we're going to try to head towards where we don't ever want a patient to say, you didn't tell me something. I
Hmm.
mean, we take a lot of time, effort, and energy to help patients. What a great tool that could literally have a timestamp on it that says, not only did we tell you, but we've told you 3 times that
Yeah.
your midline's off. I don't think a midline is necessarily something we should strive to make a priority. With that said, for the right patient, we definitely should bring it to their attention, or
For sure.
at least identify it as a problem. But there's a lot of
Yep.
other problems that I think would be brought front and center for the patient. They get overwhelmed, and this would be a great
Hmm.
place for them to come back. So, did I hear you correctly that they would have the patient would have the ability to log into this?
That's a good question. I don't see why not, because you can add anyone just with an email to access this.
Right?
I think the intention was mostly to be with providers, but I don't see why you wouldn't be able to email it to a patient.
Yeah, yeah. If you could find that out, that'd be. I mean,
Yeah,
I think you answered the question. It looks pretty straightforward. Add a team
yeah,
member. So,
yeah. So really, the feature that takes this software, I think, in my opinion, to the next level is this design feature. So it actually has an integrated smile mockup feature on this,
wow.
um, and it's the easiest one I've ever messed with. I For the sake of time, I won't go back and do step by step, but basically you just pick which photo, and then you it has an outline for the lip contour that you just kind of put the points in place, and then you have different different designs that you can pick from. I can show you here. Let's go back to.
That's really good. That's a really good rendition.
Yeah. I guess I can just do this real quick.
Yeah. While
So
you're doing
pick the
that,
photo.
Chad,
Yeah.
we have software that does this. It's called Preview.
Yeah.
I have not been able to get it to look as good as what you just did. So I'm already
Yeah.
thinking
And
this software is probably superior.
it
It's
takes.
because he's a millennial. It's immediately easier.
So you do know that depending on the definition, I'm a millennial. So whenever I am mad at somebody, I always say you're a millennial and I'm not. But when something cool happens, I say, well, I'm a millennial too. So I play both sides of the fence.
So yeah, this is where you can kind of mess with it. Each side, this you control the contours of the teeth that you want. You
Beautiful.
can control the dimensions and how much it's stretched, etc. She's a little bit asymmetric, so it's kind of hard to get hers even. But even that's good enough right there. And then you just search for the library that you want to choose, and it does it. It's done.
That's great. Being able to actually do a wax up that quickly,
Yeah.
and then send it to the lab to have the wax up done.
Yeah. So then this controls the shade down here. So for her, I was kind of going somewhere in the middle, but towards the dark end.
Yep.
And then I believe this just goes back and forth between the two. So it's literally that easy.
Wow.
And then the good thing about these is that you can also download the library of mock-up shapes, and you can. This is where the cost and stuff comes in. If you want to do send it to the laboratory for the wax up, and then to make like a digital or to do like a motivational mock-up type thing, that you can do that. But in my opinion, just the digital mock-up is 9 times out of 10 going to be all you need. And so it's as easy as that. There's even a couple other features that I haven't even messed with yet much, but there's a video that shows everything on here. It's like a 12-minute video, so if I can find the link to it online, I can email it out to everyone. It goes into more depth of what all you can do with it, and it's pretty incredible.
So I've already seen enough that I feel like we need to pull the trigger on it. Just
I agree.
Having had this program in my brain for a couple years, it didn't exist. Luke and I have talked. Every doctor has brought a different aspect of what would be ideal, and this is really it.
This thing is awesome.
Yeah.
I'm super stoked, Chad. Good find, man.
All right. Literally, it was the CE thing I was at was a full day Friday, full day Saturday, and it was all these amazing cases at these two, one guy from Brazil, one guy from Romania, and this was my take home for the whole weekend. I don't think I remember anything else because I was so focused.
Totally
on
worth it,
thinking
man.
about it. But yeah. So did anyone have any questions, thoughts, anything at all?
Can we import full mouth series bite wings?
I mean, yeah. I exported them first.
Okay.
And then just kind of submitted them as JPEGs.
Now the CAT scan, is that actually viewed?
So that's something I'm still kind of figuring out. For some reason, it's pulls up like this, and then nothing happens. I know it's possible to view it on there. I just don't think I imported it correctly. But it's got to be on the right track if I can hover over this and it
Right.
It goes through. I think just the way it needs to be imported is a little bit different than what I did. So it's possible. I just need to figure that out.
Yeah, my guess is they have a cloud-based viewing software that it uploads it to that, and then this would just be a portal to it.
Potentially,
That'd be great. I mean, how many times do we wish we had more licenses for viewing CAT scans in the office?
Yeah.
Huge game changer. This whole thing, it's incredible.
Yeah.
Definitely.
Cool.
Well, Chad and I will get some more information on pricing and what have you.
Yeah.
I can't imagine we wouldn't benefit greatly from this.
Hmm.
It's basically what we have in one place.
Exactly.
We don't have to pull up their chart and all of those separate things.
Yeah.
Videos, because we do some of the videos, functional videos, to see where they're.
I believe it can take video. I did not test that out myself yet, though.
Yep. Cool.
Yeah.
Anybody else have any questions before we? I think we're going to talk about the case specifically, and we can use this platform. So if anybody
Oh,
has
sure.
any other questions. So Chad, do you want to share with us what the prosthodontist had mentioned for suggestions?
Yeah. So this last Friday, I did a different CE course, and it was more of a treatment planning kind of workshop, if you will, with the lead guy is a prosthodontist from Florida who came up for this. It's a 4-part series of treatment planning, and then it's through the Casco Bay Study Club. So it's just the other people attending are just the local dentists and periodontists, et cetera, in town. So I brought up this one case for discussion, and basically just to kind of summarize what we are planning to do with this patient. I'll just pull up the iTero. Oh, that's a screenshot. One sec. I'll just go to the panel. The treatment plan for this patient, generally speaking, is extractions of the hopeless teeth on the bottom, some Invisalign to correct her alignment and rotations of those front teeth, and then whitening for the darkness of her teeth, and then implants in the missing teeth spots on the bottom. After our consultation with this patient that Dr. Roy and I did, we ended with the plan of doing provisional bridges from it'd be from 17 to 20, and then from 28 to 32. Doing those over the grafted extraction sites while those heal, and to give her some function while she's in ortho. That was kind of what we ended the discussion at. However, at my CE course on this past Friday, I brought that up. The overall treatment plan is exactly the same that we had come up with, but as far as the provisional bridges, the consensus was to not do that.
On both the left and the right, or just the right because it's a long span?
For both. So a couple reasons. One is the long span, especially on that one side. But two, it marries you to doing crowns on those 4 abutment teeth that would otherwise not need any treatment, as well as the space of those missing teeth could be utilized for the ortho. And if you have provisional bridges holding those spaces, then it limits your ability to use that space. So I emailed Dr. Roy on Saturday after the treatment planning thing I had, and after we had just finalized this plan, I was like, hold up, should we still do this or not? So I wanted to bring it up for discussion.
Yeah, thank you. Let me start with there is no right answer ever.
Yep.
And having these different perspectives is the true value that we're looking for by having this.
Mm-hmm.
Obviously, a prosthodontist comes with a lot of experience, a lot of knowledge. Doesn't mean they're always right, but more often than not, they're looking at these big picture things all of the time.
Mm-hmm.
I agree with what he said, but there's an exception, and I don't think this case fits that exception. So I'm a little bit on board with what he said. Zach, are you here, and can you comment on when would we want to do PMMA bridges here and why? This might not be the case. He's probably putting the kids to bed.
I'm half here. I am putting the kids to bed.
All right. I won't throw you under the bus while you're doing that. But let's just say that the patient had all of their teeth and they were all hopeless. When I say all of them in the current edentulous spaces on the bottom. So 20, let's see, that's 18 and 19, and then 29, 30, and 31. Let's say those roots were all the way down there, but all the teeth were hopeless. Would we be more likely to want to do a PMMA bridge? Again, aside from the we're sacrificing good tooth structure to do it. But if we had those teeth, what would be a potential good reason why we would want to do PMMAs? And for those who don't know, PMMAs are polymethyl methacrylate. It's essentially a temporary bridge that the lab makes. We have them reinforce it with metal wires, or we have it made out of Radica. They really don't break, despite the fact it's a long spanning bridge. Not to mention this patient would be Invisalign. I would worry about that long span breaking. I wouldn't be too happy about that long span as a biomechanically sound bridge over the next 30 years. But for the next 9 to 12 months, while we do some surgery underneath, hint, 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 why might we want to use LTPs, long-term provisional bridges?
I feel like we want to protect, especially when you're saying it's like a larger grafted area, right? There's,
Yes.
We take these big long roots out. And then if we just, we do our traditional graft and non-resorbable membrane, if we leave that exposed, I feel like over time, maybe we don't gain as much if we don't protect. And we're hoping that obviously the bridge is not going to load at all that site. It's going to, it's going to be fabricated so that it's above the surgical site and hygienic. But that's my understanding, is that we're just protecting the healing graft.
Despite the fact that you probably get the least amount of sleep of anybody here, you hit the nail on the head, at least from my perspective. So protection of a surgical site. So as a prosthodontist, you're not likely to do a whole lot of surgery. I think there definitely was a time when prosthodontists did quite a bit of crown lengthening, and maybe some of them did some surgeries, but it's not too common that you're going to see prosthodontists doing a lot of ridge grafting. What they'll typically do is send it to the oral surgeon. Well, the oral surgeon has no idea what kind of exotic treatment solutions might be out there. So what in my experience, the conversation between specialists has been the following: leave them open because I don't want you to put a partial on it. Well,
Yeah.
Obviously, if you put a partial on this, whether it's an all acrylic or it has metal, you're going to stress the site. And movement is the death knell for larger grafting. Now, what I will say is there's not a lot of grafting here that's necessarily needed, especially on the lower right side. So that's why I'm a little bit open to agreeing with the prosthodontist in this case. We can come back to that. But when it comes to sites that actually truly need large amounts of ridge grafting, let's say we're going to do an autogenous or allograft bone block with screws, some PRF, the number one predictor for the success of large ridge grafts has to do with movement or lack of movement, whether that's coming from the tissues or the muscles or the occlusion, chewing, what have you. So that's why I tend to lean towards doing bridges. And like Dr. Greenbaum said, we do it and we relieve the intaglio so that there's no contact whatsoever. We still educate the patient to try not to chew too much over there because they can still disrupt the graft. But they're really in a different state when you do that. We do this all the time now in the anterior. So rather than using flippers, we just don't do them anymore because it really, you're not going to get the best soft tissue and hard tissue outcome if you have this movable thing sitting on the top of it. So we always strive to find a solution. In the anterior, we have other things like bonded bridges, resin bonded bridges, which are essentially temporary lab fabricated Maryland bridges. There's all of these different tools that we have, Essex retainers, just bonding on a piece of composite, what have you. We want to try to minimize the amount of movement underneath. With that said, this case might not need that. So before we move back to this case, does anybody have any questions about using long-term provisional bridges to protect a surgical site during healing periods? It's one of the most powerful tools that we use at the practice. Zach, you've done a bunch of this. I'd love to hear what you have to say.
I mean, I think PMMAs are a powerful tool, and I've been to a bunch of CE at this point in my career, or a handful compared to you and David, but I've been to some CE, and this is something no one ever talks about. I mean, really, it's not really part of the conversation, and even some of the labs, when we work with them, they just want to push to go to directly to finals, but this patient has like a year of surgery in between, and that would just be crazy.
How long does it take for a ridge graft to heal?
6 months, at least.
On a good day.
Yeah. 6 months.
6 to 9 months before you can place the implants. And then you got another 4 months, sometimes longer, whenever you're placing implants in grafted bone. There might be some people here that are like, well, I don't do surgery. I don't need to know this. I firmly believe that for a patient to receive a really good treatment plan, the person quarterbacking it needs to know enough about this stuff to help make good decisions. I can't tell you how many cases we've planned like this, and for whatever reason they end up in the surgeon's office and everything gets thrown out the window. And it's not right or wrong, but we're looking at things from a different perspective than not every surgeon. There's some surgeons that understand this, and they know when to say, well, we need the restorative dentist on board here. But 9 times out of 10, the surgeon's just going to say to the patient, you'll be fine. You don't need anything there. Well, have they tested the joints? Can the patient tolerate not having posterior contacts for 9 to 12 to 2 years? Those kinds of situations happen all the time. And if you don't account for them in the beginning, that's when things start to get away from us. So the whole idea here is to literally uncover every stone so that there are no surprises. This might not be that case. Not to mention the patient's going to have Invisalign, so they're going to have some posterior support when they're not chewing. With that said, these are things we want to think of. So when it comes to grafting, always ask yourself the question, can I protect the site with a temporary bridge? Sometimes the clinical situation lends itself to having the answer yes. This is one of the exceptions, and Chad, I'm glad you brought it up. I'm not going to argue that these virgin teeth should be prepped for temporaries, but I can tell you that I've prepped virgin teeth just like this and been very confident that it was the right decision for the patient's clinical presentation. This might not be that patient.
Yeah.
But Hicks and I were talking last week about a concept, and I haven't flushed it out in my head yet, but it's something akin to sometimes being conservative is not being conservative.
Yeah.
So we ask ourselves the question, is it conservative to prep that tooth? The answer is no. Because you don't quote unquote need to. But if you look at it from a 10,000 foot view, maybe not this case, but there are cases when you look at it from a 10,000 foot view, the answer becomes actually yes, it is more conservative to prep that tooth, sacrifice the enamel for a greater good. And those situations happen all of the time. It's just thinking outside the box and being comfortable with removing enamel that doesn't quote unquote need to be removed because it's not carious or biomechanically compromised. If David, you're there, I'd love to hear your take on, do you ever sacrifice good enamel for a greater good? Because David's a very conservative restorative dentist, so I'd love to hear what he says.
I would agree with you in this case that I would not, but you could make a case for it on the left side. But yes, absolutely, there are times when I sacrifice enamel actually all the time in almost every single composite restoration because it makes it stronger.
Yeah, I know what you're talking about, the saucer shape or what does Dr. Clark call
the callally occlusal margin and the infinite margin and radius bevel.
That's a great example of you're removing a little bit more than maybe what we were taught, but I would stand behind that restoration 10 times out of 10 versus any other restoration because it seals better, it bonds better, and everything that you just said.
Yep.
Yep.
So yes, absolutely, there are times to.
Great. It's all about asking the question. It's not about just being careless. And I think there's been times when we've done treatment plans and the perception is that we're being careless. Can I say that every single tooth that I've prepared should have been prepared? No. There's definitely been times where I've, in hindsight, said to myself, maybe I could have done this another way. But I stand strong on the fact, and everybody here is the same way, we have that reflection. We have that, let's think about what we did. Did it work? Did it not work? And then incorporate that into your next decision. And that's what practicing is. It's not about making the perfect decision each and every day, because we know that normally ends up in less ideal executions, because we practice in a state of fear. Never want to practice in a state of fear. You want to practice in a state of, do I have all the information? Am I confident about what I'm doing? If I'm not, do I have the resources necessary to lean on? And that's, one of the main goals of this group, is to be able to lean on each other and bring in resources where necessary. We're never practicing alone. I think Howard Ferron from Dentaltown had said that he created Dentaltown because he wanted people to have a place where they could go and push their envelope a little bit. And that's where great clinical outcomes come. So let's all agree that these teeth do not need to benefit from long-term provisional bridges. I do agree the left side might benefit from it. But before we go there, let's ask the question: are those wisdom teeth? Those lower molars are third molars. As a employer of many recent graduates, there's still this mindset of all wisdom teeth need to come out. Not everybody here is that way, but I think there's a general kind of lack of understanding of when do wisdom teeth need to come out. Would anybody like to comment whether these teeth ultimately will come out or not, and why?
I mean, that all depends on whether or not she's cleaning them, if she can reach back there, how functional they are for her. I think in this case, if you're losing all that lower to begin with, it's worth trying to maybe save them, especially if she can reach back there and clean them.
What would be one objective tool that we could use to determine whether or not these teeth might be at high risk or not? How about a perio probe? Where would we probe to get a sense of whether these teeth are at high risk or not?
We'll be checking that distal pocketing on the tissue.
Yeah. So that is the area of risk with third molars. The distal sides tend to be encased in soft tissue because the bone is very high up on the distal part of the tooth. Why is that? Because the ramus extends superiorly in that area. It's very possible that this patient is somewhat class 3. I think we saw from the video, from the photos, that she has a somewhat prognathic mandible. Yeah, I mean that's a Bolton discrepancy 101 right there. Without a Ceph, we can't say whether or not she's skeletally or dentally class 3. But it definitely looks like she had enough room to have her wisdom teeth erupt normally. So let's go back to the pan. When we ask the question, should wisdom teeth come out? The answer is there enough mandibular skeletal arch length to support the presence of that tooth? And that sounds really obvious, but that is the answer. And we know that there was a time from an evolutionary perspective that our mandibles were larger, our jaws, both our maxilla and our mandible, were larger, and we accommodated the presence of those teeth. And through modern diets, as young kids, we don't chew hard foods, so our jaws don't develop as strongly as they should, which is why we have sleep apnea and poor nasal breathing, all of the things we've talked about before. But the space for wisdom teeth is also one of those negative ramifications that come from inadequate jaw growth. But some people have it, and I think this patient may have it without a PA and without a really good perio probing of where the attached tissue is and whether or not there's an operculum. All of those things would matter. It's an interesting question to ask because she doesn't have many good teeth back there. So what if she was to do a partial and we wanted to save those teeth for partial? We better know the periodontal status of the distal of that tooth before we put a partial on those.
Nick, I would like to go into one other direction
Absolutely.
on how to decide how long these teeth are going to last. And that direction is how long have they lasted? In other words, if this patient is 30, then I'm more concerned. If this patient is 70, I'm pretty not concerned. They've lasted that long and they still look good. The other thing is, in terms of taking care of it and caries control, she's had huge decay problems, but those teeth are not decayed. So I look at these different parameters and I say, hey, if there's any, these teeth are probably safe.
And you're talking about the wisdom teeth specifically.
Yes.
Yes. Excellent.
And I would say that's a general thing I look at in everything I do. When, a periodontal case, a patient's 5 to 6 millimeter pockets, but they're 85 years old, I'm not that concerned.
Right.
5 to 6 millimeter pockets and they're 25 years old, I'm very concerned.
So you're using their history as a maybe more subjective, but it's a subjective tool to help you with your treatment planning.
Just another data point.
Yeah, love it. I would agree. These teeth look stable. It doesn't look like there's pocketing on the distals of number 17 and 32. But those are the areas we want to look at with wisdom teeth. And like David said, if there's, if the patient is older and it's been stable, that's positive information for sure. The more data points we have, the better. Which brings me to another point. When we treatment plan, do we really look at the perio chart? I'll be the first to admit that I feel like I can treatment plan without it, which is the most asinine thing I could possibly say. The answer is no. You should never treatment plan without a perio chart because there's things in the perio chart that will help you with the decision making. And that's why having all the information in one central location is so darn helpful, so that we don't overlook any sort of data points. And as we get better at treatment planning, I think having a checklist of, have we looked at every apex on the CAT scan? Have we looked at where the mucogingival junction is in relation to areas of recession? All of these questions matter. Because the moment you start treating the patient, you own the problems, and the last thing you want to do is deal with problems that you didn't account for. So perio charting should always be part of it. And I think this particular case, knowing the periodontal health of the distals of those lower third molars would be helpful. But always ask the question, does the wisdom tooth need to come out and why? And ask yourself, is there enough jaw space there? There's a lot of times, and I'll end with this, sometimes just a gingivectomy on the distal here might be something good, but I'll agree with what Dave said. If the patient doesn't have any pocketing there, why are you going to open up Pandora's box to do that? But just keep that in mind, that when you're considering saving wisdom teeth, there's lots of things you can do to improve the health of that tooth without removing it.
Cool.
So yeah, Chad, I think, getting these teeth out, socket preservations maybe on the left side, the right side, she doesn't have enough. It looks like most likely one or two of those are just soft tissue impacted.
Yeah.
Do you want to speak a little bit about what we talked about, not removing those teeth until you have a solid plan? Do you remember what we talked about, or do you want me to repeat that? Because I think it's a very important point, specifically number 30 and 31.
Go for it. It's all you.
All right. So let's say this patient comes in and says, I want you to start just by removing these teeth. These teeth are old. They don't hurt me. They're not infected. There's no decay in them. I just want them out first. So then you ask the question, well, what's our long-term plan? The patient says, I don't know. I just want to get these out. I would make the case that these teeth, even though they're soft tissue impacted, are still preserving the bone. Some of the best bone I've ever placed implants in sit underneath these little suckers. And the reason is, when you stimulate tissue, you stimulate bone growth. The pressure from the tissue gives reason for the bone that sits underneath it to exist. So as this patient's been chewing over her maybe 30 years on these teeth, which we had talked about most likely has a strong erosive component to it. Teeth don't end up this way from parafunction alone, parafunction and erosion. The bone underneath it tends to be very good. It's akin to placing an implant underneath a primary tooth that has 100% resorbed roots, and it's just a crown just sitting on the tissue. That bone is the hardest and dense bone in the posterior mandible you'll ever see. So just be careful if you ever see these, not to jump to the gun and say, let's just take them out, if the patient is thinking about implants. Now, if she's not thinking about implants, she says, I'll never do that. That's a different story, but we always talk about never starting until you have the end in mind anyways. This is one of those times. Anybody have any thoughts or questions about that?
Would your answer change if she was having some pain, obviously?
Always, yeah.
Yeah.
Yeah, if there was infection there, absolutely. These just tend not to bother people.
Yeah.
You know, they exfoliate. When I go down to Honduras, I see a billion of these things, and they've been there for 30, 40 years, and they pluck right out. Half the time I don't even need to numb the area because there's just no inflammation around it. The body's kind of just accepted the fact that it's like a splinter and it's there, and eventually it'll just loosen up. But if there is inflammation around there, that would be a different story. Kind of like number 19. So 19 looks like it has a periapical abscess. You know, we might want to socket graft that.
Yeah. Cool. Well, thanks for the discussion on this one, guys.
Yeah, this is a great case. Has she given you any inkling on the degree of involvement she wants to get involved with? You know, she seemed on board. Her husband very much seemed on board. I think we answered his questions.
No, I think they're just figuring out the finances with Tiff.
Great.
But, do you want me to take the last 10 minutes to talk about the other thing I sent you?
Yeah, let's do it.
I hope you guys aren't tired of me talking yet.
Chad, you're doing great, man.
So the other thing at this treatment planning workshop, it was kind of started with the presentation before we got into the specific cases, but there was a really good pearl that I took home from the presentation aspect, and that the doctor, his name is Dr. Green from Florida. He came up with this Edentulous scoring index, and it really made a lot of sense to me. I don't know if you guys have heard of something like it or similar to it, but basically when you have these kind of complex cases come in where they're partially edentulous, and you need to decide whether you're getting rid of everything and cleaning house, or if you should hang on to what's there and work around that. He came up with this scoring system that kind of takes the subjectivity out of it. And so it's based on these 7 factors here that he came up with: xerostomia, patient motivation, aesthetics, the amount of teeth with a good prognosis, age, residual bone, and finances. And so what he came up with is that 4 of those he put a number to: 0, 1, or 2. So 0 is essentially ideal. So no dry mouth, really wants to keep their teeth. Implants would not be ideal, and a lot of teeth with good prognosis. And then on the other end of that is a score of 2, which is pretty severe xerostomia, doesn't really care about keeping teeth. Implants would be doable, and then not very many teeth with a good prognosis. So that puts you on a range of 0 to 8. And so the way to analyze that is if they score between 0 to 3, that you should lean towards maintaining their dentition. If they score 6 to 8, that means that you should lean towards a terminal dentition and cleaning house. And if they're in that middle range, 4 to 5, that's when you use the 3 other factors as kind of tiebreakers. So obviously if they're young, if they score 4, but they're only 35 years old, maybe you should think about maintaining their dentition. But if they're 75 and score a 4, maybe it's time to take them out anyway. So and then the finances and aesthetics as well are kind of those tiebreakers. So it made a lot of sense to me, and I was like, this simplifies everything in my head. And you can also use kind of these factors to even communicate with the patient of why you are giving them options that you do based on these factors. So I'd be very interested to hear thoughts on this?
Yeah, this is great. When we get out of school, when it comes time to condemning somebody's dentition, that's a pretty tall order. There's a lot of emotion assigned to that. Obviously, it's easy when it's an obvious case, but when it's a 4 or 5 and you've been out of school for a year,
Mm-hmm.
that's hard. And it's even hard later in your career. So to have something objective to help you, maybe not answer it, but to guide you,
Yeah.
at the end of the day, these are tools to help us provide some clarity and some understanding about a very complex topic, and that's what this does. Chad, the next few treatment plans you and I do together, let's use this and see what it does for us. I think what we should do is treatment plan without it, and then get a score after and see what it did for us, and maybe we could back test a few cases.
Yeah.
And see if that changes our outcome. I'd be a little bit hesitant because this is a different dentist perspective. Granted, it sounds like he's very astute. He's not flying by the seat of his pants. This is a very carefully drafted thing.
Yeah.
So let's see if we can incorporate this into the practice and see if it sticks.
Yeah. Anyone else have any thoughts on it?
Why does he call it a Edentulous scoring index if some of these are to keep the teeth?
That's a good question.
So maybe it's full mouth index, where you're looking at the big picture.
Yeah. No, that's a good question.
Yep.
Probably needs a new name.
Or the acronym sounds cool, ESI. So he wanted to stick with it. All right, so we have 5 minutes left. Does anybody have anything great that happened today that you'd like to share with the group?
Gordon Christensen said 4% Septicane's okay. In the latest report, it was good. I'm very excited about it. Even though Nick says that in a court of law, Gordon Christensen will not come to back you up.
No.
Are you saying for an IAN, for an inferior alveolar block?
He's saying send it. I am.
Okay. All day long.
But, he's not coming to the court.
We'll invite him.
The last study I read on from an endodontic standpoint is that if you use 2 carbocaine, you'll get as successful IANs as you would with articaine.
Oh.
And I've been doing it now for 2 years, and I would say 2 carbocaines gets it almost every single time. It's extremely rare that I need anything more.
And Dave,
And-
does it last as long?
It lasts long enough.
Yeah.
Plenty
To
long.
do restorative, you mean?
Yeah.
Okay.
The other thing is that this is anecdotal, but anecdotal for a lot of years. I have never seen a paresthesia in my practice, and most of my friends have not, except for with articaine.
Interesting.
So while I have, they say that like Malamed says 4%, it's the 4% that does it, not articaine. So Citines should be the same. But
Right.
everybody that I know because Citines and Xylo was one of the most common techniques used for IANs for years. I never knew anyone that had a paresthesia with it. As soon as when it first came out, we all went to articaine, and people started having paresthesias. So it may be anecdotal, but I think it's rare enough that you can't study it to get it. But with a sample size, a huge sample size of a lot of years of older dentists, I've seen it.
All right.
Zach, I remember when you first joined, you were all about articaine. And I remember making the point, why do you need to do that? So 4%, you're more likely to get a block. You're more likely to get a successful block. So most people think, well, I'm just going to use that then. I don't think there's any better tool in your young hands than to use something that's not that good.
Yeah.
Because I use lidocaine still. I have no idea why I would use anything else. Carbocaine is better because it stings less. The pH is a little closer to physiologic pH, what have you. So I'll often use carbocaine and lidocaine. I like the idea of using 2 carbos. I didn't know that. But I never understood why we needed to go to septicaine or articaine when lidocaine forces you to be better with your blocks because there is less room for error. So it is a little more frustrating, but over the course of a year or two, you all of a sudden become way better at your blocks. So it's a small price to pay in the beginning, and you don't end up in court where Gordon Christensen doesn't come and save you. There's enough literature out there that a litigating lawyer is going to say you shouldn't be doing it. And that's what everybody is missing. It doesn't matter what somebody says. There's enough evidence out there, anecdotal case reports, all over the literature, that all it takes is a lawyer to say, well, we don't know, and there's this study, you probably should have added that into your equation. I just don't see the advantage of doing it. Granted, it doesn't happen much. But
Clear.
if it's going to happen, it's going to happen to Zachary
Just
Regan.
clear.
All this said,
I
Articaine-
only
all this said, articaine is what I use for everything except IANs.
Amen.
Everything
Absolutely.
else.
I was gonna say that a lot of the faculty at school they'll say do a block with Lido and then follow it up with an infiltration with articaine because it'll penetrate the bone better.
And I would say to you, and this is newer because this is a whole new thing for me too, the double carbocaine has been every bit as good as Sit and Xylo that I used for years, and it doesn't have the epi. And the number one place to get epi reactions is with IANs because it's the most common place to get an intravascular injection. And
Are
that's
people
the big reason.
or getting the double injection? I mean, have you ever found that?
No problem at all. Because the first one, they feel the little pinch. If you go really slowly, it's comfortable. When you put the second one in, they don't even feel it. They feel the first little touch.
Hey, we're all about to get kicked out of Google. Love you all. This was great. Dr. Pierce, thank you for joining. Hopefully you become a regular member of the group of knuckleheads on Monday nights.
What about the black triangles that you were talking about earlier?
Yeah, we'll come back to that.